So this presentation in general has about molecular markers for follicular cell-derived thyroid cancers, molecular knowledge to clinical benefit, that is molecular testing indeterminate nodules, and tyrosine kinase inhibitors in follicular cell-derived thyroid cancer. I'll be touching about each TKI with the latest studies that have been done on them. So why are molecular markers so important? Because it helps in distinguishing between benign and malignant tumors. It predicts aggressive biology, prognosis, and risk of recurrence. It predicts efficacy of treatment as well as represents possible novel therapeutic targets. And it is also has a potential for development of personalized care treatment based on individual tumor characteristics. So follicular cell-derived thyroid cancers have essentially MAPK signaling pathways, PI3K, AKT pathways, gene translocation, amplifications, epigenetic regulation, and the progressive oncogenesis model. And the molecular markers and clinical profiles in DTCs, I'll be dealing with genetic markers, MicroRNA, long non-coding RNA markers, proteome-based markers, and molecular markers for surveillance in DTC. This includes what Dr. Sabha was saying about the liquid biopsies. So we all know, we heard about mitogen activating protein kinase pathway and phosphatidyl inositol 3 kinase and AKT pathways. And most common genetic alterations occur, and analysis have mostly been done in PTCs initially, and now all the entire array of cancers have been found to have genetic alterations. Sorry. This is the mitogenic stimuli, which acts through MEK pathway and promotes tumor promoting gene, which is most commonly, we know it is BRAF V600E. And it further activate NF-K beta, which promotes anti-apoptotic genes. Further, other pathways through MST1, and that brings down pro-apoptotic genes in the FOXO pathway. Other extracellular signal occurs through the RAS activating system that is in our follicular pathway, and that acts through ATK and PTEN and mTOR pathways, causing tumor promoting genes to increase. And finally, there is thyroid cell growth and proliferation, tumorigenesis, and progression of thyroid cancer. So the progressive oncogenesis model talks about epigenetics, that is further DNA methylation, HDAC. It talks about immune cells. Well, we heard about immune therapies nowadays. So coming on to directly onto molecular markers and their clinical profiles in DTC, start with immunohistochemical markers, that is galectin-3 and HbME1. Ma'am has already told about this, but point to be noted here is in galectin-3, 64 to 100% are present in conventional PTCs and 44 to 100% are present in FTC. They are absent in hyperplastic nodules, nodular goiters, and normal follicular epithelium. But this particular marker cannot be used as a single diagnostic marker. It has to be used in addition to a certain other marker. So HbME1 is highly expressed in both PTC and FTC, but weakly expressed in MTC and anaplastic thyroid cancer, and may be expressed in, again, adenomatoid goiter and follicular adenomas. That's when the whole crux of molecular testing comes, where we see that these may be present in benign tumors. Then there is CK19, BRAF, and podoplanin. CK19 belongs to keratin family, expressed in simple or glandular epithelium. It is a crucial marker along with a panel of other markers due to its high expression in DTC. BRAF V600E is a protein, was evaluated with a novel mutation-specific antibody called clone VE1, and BRAF mutation-specific antibody positive staining can further warrant gene mutation study. So in SGPGI, now we have BRAF mutation staining recently for our thyroid cancers. Podoplanin is a mucin-type transmembrane glycoprotein specific to the lymphatic channel. It has role in tumor cell invasion, pro-metastatic factor involved in PTC propagation. So genetic markers, PTCs, can be further classified by gene expression profiles like BRAF-like and RAS-like molecular subtypes. I won't be going into detail and talking about it. Ma'am has already said. Also, BRAF V600E in combination with third promoter mutation is linked to aggressive PTC. BRAF K601E mutation is mainly associated with follicular variant PTC. Red PTC1 and Red PTC3 arrangement are associated with aggressive phenotypes like solid variant. Then there are NRAS, HRAS, and KRAS. Other mutations are NIFTP mutations. In RAS, mutations are seen in 67%. Mutations in FTCs, that is most commonly is RAS, followed by PAX8, PTEN, PIK3CA, TSH receptor, and third promoter mutations. Then oncocytic cell carcinoma, Hürthle cell carcinomas, copy number alterations, third promoter mutations, and trisomy of chromosome 7 and 12, and mutation of GRIM19. This is very theoretical, and the applied aspects will come only in molecular testing. So microRNA markers, this is an important question for the exam going. They can be tested in FNA and liquid biopsies, and is an upcoming thing in thyroid cancer oncogenesis and diagnostic in diagnosis. So liquid biopsies such as plasma samples due to their high stability in fluids and tissue specificity. So upregulation of oncogenic microRNAs causes inhibition of apoptosis and induces cell proliferation and growth. It promotes invasion. It causes metastasis by modulating target genes of several signaling pathways. Whereas downregulation of tumor suppressant microRNAs causes loss of inhibition of cell proliferation and migration in MAP K, PI3K, AKT, NFK beta, or GSK3 beta, beta catenin pathways. So overall, it causes oncogenesis. So target genes being studied in PTC are zinc ring 3, cytokine receptor kit, or CXCL12 gene. And these microRNAs have been successfully demonstrated to be able to discriminate benign from malignant lesions in PTCs. So they can be classified into 3 and microRNAs as diagnostic markers, that is MAIR221, MAIR222, and MAIR146b. And microRNA as prognostic markers are used within MPTC to distinguish a more aggressive subtypes. MicroRNA, which can be used as therapeutic targets, are being studied in mouse models, and to come into market will take a long time. So long non-coding RNA markers, they are novel adjunct methods to distinguish malignant from benign thyroid lesions, and tissue specific and present in circulating blood, enabling the possibility of a blood sample analysis to detect the presence of thyroid cancer in future. And it is not yet clinically available. Then there are proteome-based markers, which are proteomics, have been increasingly applied to search for novel diagnostic and prognostic markers. Several proteins that may be altered in malignant lesions like prohibitin, ATP synthase D, and further preclinical and clinical studies are required to assess their clinical applicability. So we all know about serum thyroglobulin, and this is actually a circulating marker for surveillance in DTC and can be written as part of liquid biopsies. Serum thyroglobulin levels are influenced by the degree of thyroid stimulating hormone stimulation, and TG antibody is detected in 20% of thyroid cancer patients and cause unreliable and false negative TG results. Hence, the importance of thyroglobulin antibody persistence or increase leads to a 10-fold high increase of cancer persistent recurrence and 15-fold increase in cancer mortality. So when you read a report of TG, always read TG antibody along with it. So it is found that there is risk of developing lymph node metastasis, cancer persistence, and recurrence is 2 times respectively 3 times higher in antibody positive patients. So microRNA as a predictor of early relapse is all part of circulating antibodies. And once the tumor has been resected, there may be an application of declining levels of circulating microRNA after surgical resection to for prognosticating, and serum levels of microRNA on follow-up in certain studies have shown evidence of structural recurrence in even when thyroglobulin were as in thyroglobulin negative cases. The use of circulating microRNA and other circulating biomarker face several challenges, and further studies are required to address the application of in thyroid cancer diagnosis and surveillance. So this is a genetic landscape of thyroid cancer, which shows blue in PTC, FTC is mauve or purple. Then oncocytic, so this is in PTC, where we see most common as BRAF V600E, whereas in FTC, PAX8, PPAR gamma is the most common genetic alteration seen. This is the red is ATC, and you see it involves an array of genetic TP53, EIF1AX, it has RAS mutations, it has TERT mutation, and also red PTC rearrangement. Also CTNN1B, and this green is for MTC. It mostly has red mutations and can have few RAS mutations too. This is PDTC, which has most complex and involves almost all kinds of mutations, and genetic landscape is vast in PDTC. So why is molecular knowledge so important? How does it help us clinically? It helps us in molecular testing in indeterminate thyroid nodules. It is available as molecular test. There are current challenges and limitations of molecular testing, and their applications is, one of the application is TKI in different types of cancers. Also, there is an entity of impairment of iodine handling machinery in advanced thyroid cancer and in redifferentiation therapy, which I won't be touching upon. But when TKI, I'll let you know about it. So in indeterminate nodules, there's the possible management strategies range from a repeat FNA or a surveillance to diagnostic surgery for indeterminate nodules, that is Bethesda 3 to 5. Only 10 to 40% of these indeterminate nodules submitted to surgery will be malignant on histopathology. And malignancy of cytologically indeterminate nodules cannot be reliably diagnosed intraoperatively on frozen section biopsy. We all know the limitations of frozen section biopsies. So why not do a molecular testing before for an indeterminate nodule? So this is the evolution of molecular testing from where the proof of principles were laid in the late 1990s to a successful genomic testing in 2005 and advanced in 2015, and now latest in 2020 and 21. So as we see, where it was cancer was not detected earlier in 70 to 80% of cases, in more than 90% cases, the testing is more and more positive predictive value of our testing has increased over from 1990 to 2015. So what is an ideal test? There is an indeterminate cytology. There is ideal test is where the negative predictive value is very high, positive predictive value is also very high, the sensitivity is high, and a specificity is high. So that is an ideal test, and it does not exist. So we have rule in and a rule out test, where a rule in test means its positive predictive value of it saying that this is malignancy is high. So it is a very specific test. It is not a screening test. If test is positive, there is high risk of malignancy and the patient is a candidate for surgery. When we talk about rule out test, its negative predictive value is high, its sensitivity is high. So it is like a very good screening modality. So if that comes as negative, it means that patient is most likely to be benign. So test is negative, it has low risk of malignancy, and patients can be safely put for clinical observation. So we have first, second, and third generation tests. So latest one is Thyroid V3. So first generation test was a rule-in test with a sensitivity, you can see poor sensitivity, but a good specificity and positive and negative predictive value. It was a 7 gene panel. It was developed in 2011 by Verisites and Francisco. 140 uses 167 gene expression molecular assay and uses MicroRNA technology to increase the messenger RNA expression. So first generation molecular test with Afirma GEC is a rule out test. So its sensitivity is much higher than its specificity. So second generation molecular test with Thyroid V2 was developed by 2014 by CBL Path, New York, Pittsburgh. And it includes analysis of DNA level of 14 genes screened for point mutations, the analysis of microRNA to evaluate 42 gene fusions. So it can be used both as a rule in and rule out test depending on the diagnostic clinical probability of malignancy. So second generation molecular test next was developed by Laborier et al. In 2015, Thyrogen X. It's a 7 gene mutational panel with a gene expression classifier involving all these microRNA expressions. Third generation is Thyroid V3 genomic classifier and Afirma GSC. Developed by Stewart et al. With a sensitivity of 98% and a specificity of 81.8%. So if this test gives a high, if this test comes as negative, we would say that this patient can be safely kept for follow-up. It's a good rule out test. Afirma GAC is a 12 classifier composed of 10,196 genes plus 7 additional components to identify parathyroid lesion, MTC, BRAF V600E, PTC, red PTC fusions, and Hurther cell lesions. And this was developed by Patel et al. In 2018 with a 91% specificity and 68% sensitivity. So if this test comes as positive, the risk of malignancy is high. But here what we deal with is high cost of these tests, and that's why they are not very widely in use in our country even today. So validation studies need refinement to appropriately address the impact of NIFTP reclassification. We need to identify appropriate clinical scenario where molecular testing might be useful, as well as the interpretation of results is challenging and might result in over or under treatment. And from studies, it has been known that only 7.9 to 8.4% of patients had altered surgical decision making as a result of molecular testing. So it's very important to know where and which molecular testing to be applied. And it has not been validated in pediatric patients now. Correlation between presence of mutations and occurrence of malignancy is imprecise, since benign nodules may also harbor mutations, while some malignancies have done detectable with commonly used, non-detectable commonly used platforms. They are expensive and reports on cost effectiveness are conflicting, not available worldwide, and delays of treatment need to be considered and weighed up against the benefits. And molecular markers, marker negative patient lack histological confirmation on a surgical specimen. That is the most basic negative aspect of it. And final diagnosis can never be established. Only we can believe that this report is such, and hence the patient can be kept on follow-up. So coming on to TKIs in differentiated thyroid cancers, TKI are tyrosine kinase inhibitors, and they are considered for patients with progressive or symptomatic disease as assessed by RECIST criteria. So radioactive iodine refractoriness is seen in around 5% of patients with loco-regional DTCs and 50% of patients with metastatic DTC. And that can be one reason why none of our iodine therapies are going to work on such patients, and TKI becomes an important treatment aspect in such patients. So tyrosine kinases are involved in MAP K kinase signaling pathways through phosphorylation and dephosphorylation of intracellular proteins. And in differentiated thyroid cancers and in commonly used in our practices are lenvatinib and sorafenib, which have proved their efficacies in randomized phase 3 trials and become a standard of care in patients with DTC based on SELECT and DECISION trials respectively. So before coming on to SELECT and DECISION trial, other TKIs, I want to go through this sorafenib with the DECISION trial and lenvatinib SELECT trial. It's an important exam question. So here sorafenib was used at a maximum dose of 400 mg BD. It was actually the dose that was used was 200 mg. And the targets of sorafenib are RAF, VEGFR 1 to 3, PDGFR, c-KIT, and RET. Whereas in lenvatinib, it is FGFR 1 to 4, VGFR 1 to 3, RET, c-KIT, and platelet-derived growth factor alpha. Treatment was first line, whereas in lenvatinib, it was first line or progress to previous TKI with the maximum one with the 25% as in with one TKI, there was 25% progression of disease. Population was recessive disease progression within the previous 14 months. And on lenvatinib also, there was progression within the previous 13 months. Histology was most commonly was papillary, followed by follicular, and then PDTC. As in lenvatinib group, it was papillary, followed by follicular, then Hürthl cell, and poorly differentiated. Most common site of metastasis was bone in the sorafenib group and as well as the lenvatinib group. Comparator arm in both was placebo, and crossover placebo intervention was allowed, and that is if a patient was developing symptoms on placebo, the randomization was the blinded part was removed, and then it was checked if the patient was on placebo, and the patient was started on sorafenib and vice versa. Randomization was 1:1, and for lenvatinib was 2:1, and progression-free survival was the primary endpoint. And secondary survival was overall survival, disease-free survival, and with the recurrence. So results of DECISION trial was there was overall survival seen in 39.4 versus 42.8 months. That is 52.8 versus 54.8% death in 8 years duration. Is in lenvatinib group, it was 41.6 versus 34.5 months. And the effects were very significant with the p-value of less than 0.001. However, the common side effects in sorafenib group was hand-foot syndrome. That is around 37% of the patient presented with that. Whereas in lenvatinib, because it mostly targets fibroblast growth factors and VEGFR, it was hypertension. Where other common side effects was mild nausea, vomiting, and hypothyroidism in both the arms. 64% of the patients require dose reduction, and in the same tune, dose reduction was required in lenvatinib. The highest dose of lenvatinib used, I think, in this was 14 mg, and therapy discontinuation was used in had to be done in 19% of sorafenib arm and 14% in lenvatinib arm. So going on each one by one. Sunitinib, also known as by its number SU 011248, it is a small molecular weight multi-kinase TKI, and it inhibits preferentially RET PTC subtypes 1 and 3, where it's seen in aggressive histology as already discussed, VEGFR 1 and 2 and 3, and KIT and PDGFR kinases. So sunitinib was actually initially approved from FDA for gastrointestinal stromal tumors and for RCCs, and it has been also studied in multiple phase 2 and multicentric retrospective trials in thyroid cancers. So cure rate, persistent rate, and progression-free survival was in the tune of 13.1 month in metastatic MTC, 9.8 months in metastatic ATC, and 16.5 months in metastatic MTC patients. So the most common side effects of drug-related side effects of sunitinib are hand-foot syndrome, fatigue, neutropenia, diarrhea, hypothyroidism, and hypertension. But it is not commonly used over sorafenib, which is more commonly used than sunitinib. So sorafenib, in one of its studies, in the phase 2 study in 18 Japanese patients, is the above 3 slides. It's a busy slide, but all you have to know in this is the name of the trial and what was the progression-free survival. So as sorafenib acts very well in PTC, it may not act that well in ATC, and it has only 2.8 months may give patient 2.8 months without in progression-free survival, and no PFS in MTC patients in this particular study. However, we commonly use sorafenib in our MTC patients when cost becomes an issue. So sorafenib, as already discussed, is a multi-kinase inhibitor, inhibits preferentially RAF, VGFR2, PDGFR 2 and 3, RET, and KIT kinases. It has good uses in RAI refractory metastatic DTCs, where it has given 10.8 months of disease progression-free survival, and 6 months for sunitinib as a second-line therapy. However, diarrhea, fatigue, anorexia, hypertension, mucocutaneous effects were seen. Coming over on to vandatinib. Vandatinib has been mostly studied in MTC patients. It's a potent inhibitor of VEGFR2, 3, RET, and EGFR kinases. And it was initially actually evaluated in hereditary MTC, and comparable preliminary data was reported in 2 phase 2 trials with a progression-free survival of around 16.1 months, with common side effects of skin toxicity, mostly rashes, photosensitivity, gastrointestinal upset, and prolonged QT interval in some patients. Other phase 1 and phase 2 trial in 14 Japanese patients with unresectable locally advanced metastatic MTC showed some progression-free survival at 12 months was 85%. Then the next trial of vandatinib is still ongoing, and the progression-free survival is yet to be recorded. And part B, as you can read on the left side of the column, the certain part of this trial which is ongoing. Then most studies have been done for lenvatinib, which effectively inhibits fibroblast growth factor 1, 2, 3, 4, platelet-derived growth factors, VEGFR 2, 3, RET, and KIT kinases. It has been FDA approved for treatment of advanced RAI refractory DTCs. So the two most common drugs that we use for RAI refractory DTCs is sorafenib and lenvatinib. So this drug has been studied in multiple phase 1, phase 2 trials, and a few phase 3 trials also. Forgetting the name of this trial other than select. So it in few of the studies, it gives a good progression-free survival of 12 to 18 months. The most common side effect, as you can see here, is hypertension and diarrhea. also hypothyroidism. So this has to be gradually increased step by step with the dosing, and patient has to be tested for hypertension and urine proteinuria, and TSH have to be done at least 3 to 6 monthly when patient is on lenvatinib. Other issue is cost issue, but nowadays the cheaper variant are available in Indian markets. So yeah, the name of the trial is select here. There's another one. Sorry, I'm forgetting the name of this trial for lenvatinib. So certain other trials, as previously seen, was showing 16 to 18 months. In one of these trials, that is phase 2 trial, this particular trial is 25.8 months for refractory DTC. So lenvatinib is actually slowly proving to be a good drug in RAI refractory DTTs. So other drug which has been essentially studied in MTCs has also been studied in RA refractory DTC, that is cabozantinib. And here cabozantinib inhibits MET, KIT, VEGFR, VEGFR2 and RET kinases. So my last drug that discussing is dabrafenib and trametinib. Dabrafenib is a BRAF kinase inhibitor, and it shows proliferative effects in vitro in human colon cancer xenografts with and BRAF V600E positive melanoma patient, and hence it has been FDA approved for ATCs and BRAF mutated PDCs. So a few of this trial is still not reached the stage of progression-free survival, and in other studies of ATC, 3.7 months in the entire cohort has been seen with progression-free survival. Most common side effect is fatigue, pyrexia, and nausea. So this slide I've already gone through. So we've already gone through other multi-TKI currently which are being evaluated under phase 3 clinical trials. Vandetanib has reached a phase 3 trial verify, and BRAF V600 inhibition has also been considered in patients with DTC harboring BRAF V600E mutation, achieving an overall survival between 30 to 40%. So this picture has an overview of the current treatment approach in MTC, and I'll not be going through it in detail. It also includes immune cell targets and the targets of PI3K and RAS pathways. And this is an overview of the current treatment approach in ATC, where in immune cell, this particular thing is in studies now, where PDL1 and CTLA4 targets are being used for ATCs. Yeah, thank you.